Hello friends, today we are going to discuss 2021 guidelines of heart failure. In this we will mainly discuss about the acute heart failure. Acute heart failure refers to the rapid and gradual onset of symptom and signs of heart failure severe enough for patient to seek urgent medical attention, leading to unplanned hospital admission or emergency department visit. Patient with acute heart failure requires a urgent evaluation with subsequent initiation and intensification of the treatment, including IV therapies or procedures. Acute heart failure is the leading cause of hospitalizations in subject aged more than 65 years and is associated with high mortality and rehospitalization rate. In-hospital mortality ranges from 4% to 10%. Post-discharge 1 year mortality can be 25 to 30% with up to more than 45% death or readmission rate. Clinical presentation, acute decompensated heart failure. Acutely decompensated heart failure, it is the most common form of acute heart failure, accounting for 50% to 70% of presentations. It usually occurs in patients with history of heart failure and previous cardiac dysfunction across the spectrum of left ventricular ejection fraction and may include RV dysfunction. Distinct from the acute pulmonary edema phenotype, it has a more gradual onset and main alteration is progressive fluid retention responsible for systemic congestion. Sometimes congestion is associated with hypoperfusion. Acute pulmonary edema is related to the lung congestion. Clinical criteria for acute pulmonary edema diagnosis, including dyspnea with orthopnea, respiratory failure, tachypnea more than 25 breaths per minute, and increased work of breathing. Three therapies should be commenced if indicated. First, oxygen given as continuous positive airway pressure, non-invasive positive pressure ventilation, or high flow nasal cannula should be started. Second, IV diuretic should be administered. And third, IV vasodilators may be given if systolic BP is high to reduce LV afterward. In few cases of advanced heart failure, acute pulmonary edema may be associated with low cardiac output, and in this case, inotropes, vasopressor, and MCS are indicated to restore organ perfusion. Isolated right ventricular failure. Right ventricular failure is associated with increased RV, atrial pressure, and systemic congestion. RV failure may also impair the LV filling, ultimately reduce the systemic cardiac output through ventricular interdependence. Diuretic are often first option of therapy for venous congestion. Noradrenaline and inotropes are indicated for low cardiac output and hemodynamic instability. Inotropes reducing the cardiac filling pressure may be preferred. Since inotropic agent may aggravate arterial hypotension, they may be combined with norepinephrine if needed. Cardiogenic shock is the syndrome due to primary cardiac dysfunction resulting in inadequate cardiac output, compromising life-threatening state of tissue hypoperfusion, which can result in multi-organ failure and death. Cardiac insult causing severe impairment of cardiac performance may be acute as a result of acute loss of myocardial tissue or may be progressive, as seen in patients with the chronic decompensated heart failure who may experience decline in disease stability as a result of natural progression of advanced heart failure or specific precipitate. Diagnosis of cardiogenic shock mandates the presence of clinical signs of hypoperfusion, such as cold sweated extremities, oliguria, mental confusion, dizziness, narrow pulse pressure. In addition, biochemical manifestation of hypoperfusion, elevated serum creatinine, metabolic acidosis, elevated serum lactate are preset and reflect the tissue hypoxia and alterations of cellular metabolism leading to organ dysfunction. Of note, hypoperfusion is not always accompanied by hypotension, as BP may be preserved by compensatory vasoconstriction, albeit at the cost of impaired tissue perfusion and oxygenation. Management of cardiogenic shock should start as early as possible. Early identification and treatment of underlying cause, concomitant with the hemodynamic stabilization and management of organ dysfunction, are key components of its management. The clinical presentation of acute heart failure, acute decompensated heart failure, acute pulmonary edema, isolated right ventricular failure, and cardiogenic shock. So if the patient is presenting with the Acute decompensated heart failure. The main hemodynamic abnormalities are increased left ventricular end diastolic pressure, pulmonary capillary wedge pressure, low or normal cardiac output, normal or low SP. Main clinical presentation is wet, warm or wet or cold extremities. And the main treatment is diuretic, inotropic agent, vasopressors. Short-term MCS or RRT if indicated. Acute pulmonary edema. If patient presents with the acute pulmonary edema, the main hemodynamic abnormalities are increased left ventricular end diastolic pressure, pulmonary capillary wedge pressure, normal cardiac output, and normal and high SPP. Main clinical presentation is wet and warm extremities, and main treatment is diuretics and the vasodilators. Then isolated right ventricular failure. The main mechanism is RV dysfunction and precapillary pulmonary hypertension. Main cause of symptom is increased CVP and often systemic hypoperfusion. Main hemodynamic abnormalities are increased right ventricular end diastolic pressure, low cardiac output, low SP. Clinical presentation is wet and cold extremities. Main treatment is diuretic for peripheral congestion, inotropic agent, vasopressor, short-term MCS or RT. Cardiogenic shock, the main mechanism is severe cardiac dysfunction. Main cause of symptom is systemic hypoperfusion. Main hemodynamic abnormalities are increased left ventricular diastolic pressure, pulmonary capillary wedge pressure, low cardiac output, and low SPP. Main treatment is main inotropic agent, vasopressor, short-term MCS, and RT. The diagnostic workup for acute heart failure start at the time of first medical contact and is continued throughout the initial patient pathway, aiming to identify the clinical presentation and to diagnose and manage any potentially reversible causes, precipitant, coexisting life-threatening condition in timely manner. In addition to the clinical signs and symptoms, diagnostic workup include ECG, echocardiography if possible. Additional investigations, static chest X-ray, lung ultrasound may be used to confirm acute heart failure diagnosis, especially when NT-proBNP testing is not available. Plasma NP levels should be measured if diagnosis is uncertain and point of care assay is available. Normal concentration of natriuretic peptide make the diagnosis of acute heart failure unlikely. Cutoff for acute heart failure are PNP less than 100, proBNP less than 300, and MR NP less than 120. However, elevated NP values are associated with a wide range of cardiac and non-cardiac conditions. Low concentration is detected in some patients with advanced decompensated end-stage heart failure, obesity, flash pulmonary edema, or right-sided acute heart failure. High levels can be found in the patients with concomitant atrial fibrillation or reduced renal function. Detection of abnormal liver function identifies patient with poor prognosis. Since both hypothyroidism and hyperthyroidism may precipitate acute heart failure, thyroid stimulating hormone should be assessed in those with newly diagnosed acute heart failure. ABG should be performed when precise measurement of O2 and CO2 partial pressure is needed. Lactate and pH level should be measured in patients with cardiogenic shock. D-dimer should be measured when acute pulmonary embolism is suspected. ECT may be used for diagnosis of pneumonia, and antibiotic therapy may have indication when plasma level more than 0.2. However, no impact of strategy based on routine PCT measurement on outcome was shown in prospective control trial. Pulse oximetry should be measured routinely at the time of first presentation of patient with acute heart failure, and continuous monitoring may be needed in first hours or days. So this is the diagnostic workup of new onset of acute heart failure. Patient's history, signs, symptoms suspected of acute heart failure. It includes ECG, pulse oximetry, echocardiography, initial lab investigation, chest X-ray, lung ultrasound, and other specific evaluation. Then natriuretic peptide test. If BNP is less than 100, then acute heart failure is ruled out. If more than 100, NT-proBNP more than 300, MR-proBNP more than 120, acute heart failure is confirmed and the comprehensive echocardiography is needed. So the diagnostic test in patient with the acute heart failure include ECG, chest X-ray, lung ultrasound, echocardiography, NT-proBNP, serum troponin, serum creatinine, serum electrolytes, iron status, TSH, D-dimer, ECT, lactate, pulse oximetry, NH. Now, regarding management, in the pre-hospital setting, acute heart failure patients should benefit from non-invasive monitoring, including pulse oximetry, BP, heart rate, respiratory rate, continuous ECG monitoring, instituted within the minutes of patient contact, and the ambulance if possible. Oxygen therapy may be given based on the clinical judgment unless oxygen saturation is less than 90%, in which case it should be administered. In patients with respiratory rate more than 25 breaths per minute, oxygen saturation less than 90%, non-invasive ventilation should be initiated. Pre-hospital management should not delay the rapid transfer of acute heart failure patient to most appropriate medical setting. In hospital management, diagnostic workup and appropriate pharmacological, non-pharmacological treatment must be started promptly and in parallel. Acute heart failure patients are triaged to appropriate level of care according to the degree of hemodynamic instability and severity of critical illness. The type and intensity of in-hospital monitoring depends on the clinical severity, setting of care, and in-hospital course. As acute heart failure is heterogeneous condition, management may differ according to the main clinical presentation. Management starts with the search of specific cause of acute heart failure. This include ACS, hypertensive emergency, rapid arrhythmias, severe bradycardia, conduction disturbances, acute mechanical causes such as acute valve regurgitation, acute pulmonary embolism, infection including myocarditis and tamper. After exclusion of this condition, which need to be treated and corrected urgently, management of acute heart failure differs according to the clinical presentation. Management of patient with suspected acute heart failure. Cardiogenic shock in the respiratory failure. If yes, then pharmacological support, ventilatory support, or a mechanical circulatory device. If no, then we have to identify the acute etiology. That is acute coronary syndrome, hypertension emergency, arrhythmia, mechanical causes, pulmonary embolism, infection, tampon. If yes, then initiate specific treatment. If no, then further treatment is required. Oxygen therapy and ventilator support in acute heart failure. Oxygen should not be used routinely in non-hypoxemic patients as it causes vasoconstriction and reduction in cardiac output. Oxygen therapy is recommended in patients with acute heart failure and SpO2 of less than 90%, PO2 of less than 60 mmHg to correct hypoxia. In COPD, hyperoxygenation may increase the ventilation perfusion mismatch, suppress ventilation, and leads to hypercapnia. During During oxygen therapy, ABG and SpO2 should be monitored. Non-invasive positive pressure ventilation, either continuous positive airway pressure. Hello, हाँ बोलो ना. नहीं, कैंसिल होने वाले. तुम लोग का है? हाँ क्या? कौन ले रहा है? आप ही ले रहे हो ना? ये उसका क्या हुआ? वो अनुजा पेशेंट का क्या हुआ? उसका CRT चल रहा है. अनु तो डायग्नोसिस क्या था उसका? तो हम लोग इनको तो चले. तो वेरी कुछ दिया नहीं हुआ. सब क्लियर हुआ. Non-invasive positive pressure ventilation, either continuous positive airway pressure or pressure support, improves the respiratory failure, increases the oxygenation pH, decreases the partial pressure of carbon dioxide, and work of breathing. Although large randomized trials had neutral results, meta-analysis suggests it may improve dyspnea, reduce the need of intubation and mortality compared with the traditional oxygen therapy. Non-invasive positive pressure ventilation should be started as soon as possible in patients with respiratory distress to improve gas exchange and reduce the rate of intubation. Blood pressure should be monitored regularly during non-invasive positive pressure ventilation. The increase in intrathoracic pressure with non-invasive positive pressure ventilation increase the venous return and right and left ventricular preload. It may also decrease the cardiac output and BP and should therefore be used with caution in patients with the reduced preload reserve and hypotension. The increase in the pulmonary vascular resistance and RV afterload may be detrimental in RV dysfunction, and intubation is recommended for progressive respiratory failure in spite of oxygen administration and NF. The intravenous diuretics are the cornerstone of acute heart failure treatment. They increase the renal excretion of the salt and water and are indicated for treatment of fluid overload and congestion in the vast majority of acute heart failure patients. Loop diuretics are commonly used due to their rapid onset of action and efficacy. Data defining their optimal dosing and their limiting and the method of administration are limited. No difference in the primary efficacy outcome of the patient's symptom global assessment was shown with high dose regimen compared with the low dose regimen in the dose trial. However, there was greater relief of the dyspnea, change in weight, and net fluid loss in high dose regimen. High diuretic doses may cause greater neurohormonal activation and electrolyte abnormalities and are often associated with a poor outcome, although the cause and effect of relation cannot be proven by these retrospective analyses. Based on these observations, it may be appropriate when starting IV diuretic treatment to use low dose and to assess the diuretic response and increase the dose when that is insufficient. Diuretic treatment should be started with initial IV dose of furosemide of equivalent dose of bumetanide and torsemide, corresponding to 12 times the daily oral dose taken by patient before admission. If the patient was not on the oral diuretic, starting dose of 20 to 40 mg of furosemide and bolus of 10 to 20 mg of IV torsemide can be used. Furosemide can be given as 2 to 3 daily bolus or continuous infusion. Daily single bolus administration are discouraged because of the possibility of the post-dosing sodium retention. With continuous infusion, loading dose may be used to achieve steady state again. Diuretic response should be evaluated shortly after the start of diuretic therapy and may be assessed by performing spot urine sodium content measurement after 2 or 6 hours and by measuring the hourly urine output. Satisfactory diuretic response can be defined as urine sodium content more than 50 to 70 milliequivalent at 2 hours and by urine output 100 to 150 ml per hour during first 6 hours. There is insufficient diuretic response. The loop diuretic IV dose can be doubled with further assessment of diuretic response. If diuretic response remain inadequate, that is less than 100 ml per hour diuretic response, despite doubling loop diuretic dose, concomitant administration of other diuretic acting at different site, namely thiazide, metolazone, or acetazolamide may be considered. However, this combination requires careful monitoring of serum electrolyte and renal function. This strategy, based on early and frequent assessment of diuretic response, allowed starting treatment with relatively low dose of loop diuretic with frequent dose adjustment that may be less likely to cause dehydration and increase in serum creatinine. The loop diuretic dose should be progressively decreased when the significant negative fluid balance has been obtained. However, it should be pointed out that this algorithm is entirely based on expert opinion to date. Transition to oral treatment should be commenced when the patient's clinical condition is stable. It is recommended that after achievement of the congestion relief, the oral loop diuretic are continued at lowest dose possible to avoid congestion. Care must also be taken to avoid patient being discharged from hospital with persistent congestion, as this is the major predictor of increased death and rehospitalization. Hence, care should be taken to achieve adequate decongestion and establish an appropriate long-term diuretic dose before discharge. So, management of the diuretic therapy in patient with acute heart failure. So, the patient is on the oral loop diuretics. If uh, uh, then continue with the 1 to 2 times daily oral dose. That is, we can given it as IV. If patient is not on loop diuretic, then we can give more than 20 to 40 mg IV furosemide. Then measure urine spot sodium and urine output. Urine spot sodium after 2 hours. And urine spot sodium after 2 hours if it is more than 50 to 70 milliequivalent, and urine output after 6 hours if it is more than 100 to 150. Then repeat similar dose IV every 12 hours. If no, then double the dose IV after maximum IV dose. Then reassess again urine spot sodium and urine output. If urine spot sodium is 50 to 70 at 2 to 6 hours and urine output is more than 100 to 150, then continue until the complete congestion. If no, then the combination of diuretic therapy should be used. Then the next class of drug is vasodilator. Intravenous vasodilator, namely nitrate, nitroprusside, dilate venous and arterial vessel, leading to the reduction in venous return to heart, less congestion, lower afterload, and increased stroke volume, and consequent relief of symptoms. Nitrate act mainly on the peripheral vein, where nitroprusside is more balanced, arterial and venous dilator. Because of their mechanism of action, IV vasodilator may be more effective than the diuretics in those patients whose acute pulmonary edema is caused by increased afterload and fluid redistribution to the lung in the absence or with minimum fluid accumulation. However, two recent randomized trials comparing usual care with early intensive and sustained vasodilation failed to show beneficial effect of IV vasodilator versus high dose diuretic. No recommendation favoring regimen based on vasodilator treatment versus usual care can thus be given to the dictum. Intravenous vasodilator may be considered to relieve acute heart failure symptoms when SPP is more than 110 mmHg. They may be started at low doses and up-titrated to achieve clinical improvement in BP control. Nitrates are generally administered with initial bolus followed by continuous infusion. However, they may be given as a repeated bolus. Nitroglycerin can be given as 12 mg bolus in severely hypertensive patients with acute pulmonary edema. Care should be taken to avoid hypotension due to excess decrease in preload and afterload. For this reason, they should be used with extreme caution in patients with LVH or severe aortic stenosis. However, favorable effects were described in patients with LV systolic dysfunction and aortic stenosis when vasodilator were given with careful monitoring of the hemodynamic parameter. Regarding inotropes are still needed for treatment of patients with low cardiac output and hypotension. They should be reserved for patients with LV systolic dysfunction, low cardiac output, and low SPP, resulting in poor vital function perfusion. However, they must be used with caution, starting at low doses and titrating them with close monitoring. Inotrope, especially with the adrenergic mechanism, can cause sinus tachycardia, increase ventricular rate in patients with atrial fibrillation, and it may induce myocardial ischemia and arrhythmia and increase mortality. Levosimendan and type 3 phosphodiesterase inhibitor may be preferred over dobutamine for patients on beta blocker as act through independent mechanism. Excessive peripheral vasodilatation and hypotension are the limitation of levosimendan and type 3 phosphodiesterase inhibitor. Vasopressors are used for treatment of acute heart failure. Among drugs with the prominent peripheral arterial vasoconstrictor action, norepinephrine may be preferred in patients with severe hypertension. The aim is to increase perfusion to vital organs. However, this is at expense of LV after. Therefore, combination of norepinephrine and inotropic agent may be considered, especially in patients with advanced heart failure and cardiogenic shock. Some studies, though with limitations, support the use of norepinephrine as first choice compared with dopamine and epinephrine. Dopamine was compared with norepinephrine as the first-line vasopressor therapy in patients with shock and was associated with more arrhythmic event and with greater mortality in patients with cardiogenic shock, but not in those with hypovolemic or septic shock. These data are consistent with meta-analysis, including 2,583 patients with cardiogenic shock, showing threefold increase in risk of death with epinephrine compared to norepinephrine in patients with cardiogenic shock. So, inotropes and vasopressors used to treat acute heart failure. Dobutamine 2 to 20 microgram per kg per minute. Dopamine dopamine 3 to 5 microgram per kg per minute. And more than if it is used in more than 5 microgram per kg per minute, then it has inotropic and vasopressor both action. Mendrinone can be used in the dose of 0.375 to 0.75 microgram per kg per minute. Enoxenone can be used in the dose of 5 to 20 microgram per kg per minute. Levosimendan can be used in the dose of 0.1 microgram per kg per minute, which can be decreased to 0.5 or can be increased to 0.2 microgram per kg per minute. Norepinephrine can be started in the infusion of 0.2 to 1 microgram per kg per minute. Epinephrine 0.05 to 0.5 microgram per kg per minute. Opioid relief dyspnea and anxiety. This may be used as sedative agent during non-invasive ventilation to improve patient adaptation. Dose-dependent side effects include nausea, hypotension, bradycardia, and respiratory depression. Morphine administration is associated with greater frequency of mechanical ventilation, prolonged hospitalization, more intensive care admission, and increased mortality. Thus, routine use of opioid is not recommended, although they may be considered in selected patients in case of severe intractable pain, anxiety, and setting of palliation. Digoxin should be considered in patients with atrial fibrillation with rapid ventricular rhythm, despite beta blocker. It can be given in the bolus of 0.25 to 0.5 mg IV if not used previously. However, in patients with comorbidities and the other factors affecting digoxin metabolism or elderly, maintenance dose may be difficult to estimate theoretically, and measurement of serum digoxin concentration should be performed. Digoxin is potential alternative to digitoxin is potential alternative to digoxin and is currently being evaluated in randomized placebo-controlled trial. Thromboprophylaxis with heparin and other anticoagulant is recommended unless contraindicated. Short-term mechanical circulatory device. In patients presenting with cardiogenic shock, short-term MCs may be necessary to augment cardiac output and support end organ perfusion. Short-term MCs can be used as bridge to replacement, bridge to transplant. The initial improvement in the cardiac output, BP, and arterial lactate may be counterbalanced by significant complications. High quality evidence regarding outcome remains scarce. However, unselected use of the MCS in patients with cardiogenic shock is not supported, and they require specialist multidisciplinary expertise for implantation management, similar to that outlined for advanced heart failure center. The recent study shows the standardized team-based approach using predefined algorithms for early MCS implant coupled with the close monitoring may potentially translate into improved survival. The intra-aortic balloon pump in cardiogenic shock (IVP shock trial) showed no difference in 30-day as well as long-term mortality between IVP and optimal medical therapy in patients with cardiogenic shock following acute MI who underwent early revascularization. According to these results, IVP is not routinely recommended in cardiogenic shock post-MI patients. However, it may be considered in cardiogenic shock, especially if not due to ACS and refractory to drug as a bridging therapy. Other short-term MCS were compared with IVP in small randomized trial and the propensity match analysis with unconclusive results. Similarly, RCT comparing extracorporeal membrane oxygenation with IBP and or MT are lacking. Meta-analysis, including only observational studies, showed favorable outcome in patients with cardiogenic shock and cardiac arrest treated with VA ECMO compared to control. VA ECMO may also be considered in fulminant myocarditis and other conditions causing severe cardiogenic shock. Depending upon the severity of myocardial dysfunction or concomitant mitral or aortic regurgitation, VA ECMO may increase the LV afterload with increased LV end diastolic pressure and pulmonary congestion. In this case, LV unloading is mandatory and can be achieved by means of transeptal and ventricular apex vent and adding unloading device such as impella device. So recommendation for initial treatment of acute heart failure. Oxygen is recommended in patients with SpO2 less than 90, PO2 less than 60. Intubation is recommended for progressive respiratory failure. Now, NIV should be considered in patients with the respiratory distress, like respiratory rate more than 25, SpO2 less than 90. Started as soon as possible in order to decrease respiratory distress and reduce the rate of mechanical endotracheal intubation. Intravenous loop diuretics are recommended for all patients admitted with the signs and symptoms of fluid overload. Combination of loop diuretic with thiazide diuretic should be considered in patients with the resistant edema who do not respond to increased loop diuretic doses. In patients with acute heart failure and systolic blood pressure more than 110, IV vasodilator must be considered. Inotropic agent may be considered in patients with SPP less than 90 mmHg, evidence of hypoperfusion who do not respond to standard treatment, including fluid challenge. Inotropic agents are not recommended routinely due to safety concern unless the patient has symptomatic hypotension, evidence of hypoperfusion. A vasopressor, preferably norepinephrine, may be considered in patients with cardiogenic shock to increase blood pressure and vital organ perfusion. Thromboembolism prophylaxis is recommended in patients not already anticoagulant and with no contraindication to anticoagulation to reduce the risk of DVT and pulmonary embolism. Routine use of opioid is not recommended unless in selected patients with severe and intractable pain or anxiety. Now, recommendation of short-term mechanical circulatory device. Short-term mechanical circulatory device should be considered in patients with cardiogenic shock as a bridging therapy. That is bridge to decision, bridge to recovery, and bridge to bridge. Further indication include treatment of the cause of cardiogenic shock and long-term MCS or transplantation. IABP may be considered in patients with cardiogenic shock as a bridging therapy, including the treatment of cause of cardiogenic shock and long-term MCS or transplantation. IABP is not routinely recommended in post-MI cardiogenic shock. Thank you, guys.